If LDL-C is the number we have all been trained to chase, ApoB is the one quietly telling the real truth. It doesn't care how polished your cholesterol panel looks. It counts every single particle capable of causing atherosclerosis. Because, in the end, it's the particles, not the cholesterol, that injures the arterial wall. Cholesterol is just the passenger. ApoB marks the vehicles delivering the cholesterol damage. Welcome to LipidCurious, the podcast dedicated to demystifying lipids for medical boards and real-world clinical practice. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. This is Season 1, Episode 7, ApoB, short for Apolipoprotein B. Here's what we'll cover together. 1. Why ApoB is a better measure of atherogenic burden. 2. How ApoB drives atherosclerosis. 3. How ApoB fits into clinical practice. If you did like some practical lipid guides, quick reference charts, and cheat sheets for your everyday clinic practice, grab your free starter kit at www.lipidcurious.com. And as always, this show is for educational purposes only, not medical advice. All right, let's dive in. So what exactly is ApoB and why has it suddenly become everyone's favorite truth teller in lipidology? In our last episode, we talked about lipoproteins, the tiny spherical particles that carry lipid cargo through the bloodstream. ApoB sits on the surface of every atherogenic lipoprotein. It gives them their identity. It communicates their place of origin as well as their final destination. There are two main forms. 1. ApoB48. This is made in the intestine, which tags along on chylomicrons and their remnants, which carry the dietary fat. 2. ApoB100, which is made in the liver. This is found in VLDL, IDL, LDL, and lipoprotein little, the real troublemakers when it comes to atherosclerosis. And remember, HDL particles do not have an ApoB. So there is some functional difference between these two forms as well. ApoB100 is like a key. It allows these particles carrying ApoB100 to dock in with the LDL receptors on the liver so it can be accepted into the liver. On the other hand, ApoB48 coming from the intestine does not have the docking site, so its job is mainly post-meal fat transport. Although the typical lab assays can detect both the isoforms of the ApoBs, what you see on your lipid report is almost entirely ApoB100, representing the liver-derived atherogenic lipoprotein particles. Each lipoprotein particle carries exactly one ApoB. That means your ApoB level is essentially a particle count, the total number of vehicles in circulation. That's why ApoB is so powerful. It captures the number of particles capable of injuring the arterial wall. Most ApoB in the blood, over 90%, comes from LDL particles, simply because they are the most numerous. Compare that to LDL-C. LDL-C only tells you how much cholesterol is inside the LDL particles. It doesn't communicate how many particles are there. Let's picture this. Imagine there is 100 pounds of sand. You could either carry it in 5 large 20-pound basketballs or 50 teeny tiny 2-pound golf balls. So both of them, the weight is still 100 pounds, but the number of particles is different. One side there are 5 basketball size, so big and large particles, and the other side are tiny golf balls, which are more particles but smaller in size. But 50 golf balls means 50 opportunities to hit the arterial wall. That's LDL-C versus ApoB in a nutshell. LDL-C is just the weight of the cholesterol inside these particles. ApoB tells you about how many particles are carrying this weight. Smaller the particles, the more atherogenic they are because they can hit the arterial wall more often. So 2 patients might have the same LDL-C, but the one with the higher ApoB which means more particles, faces the higher cardiovascular risk. Large studies like Amoris, Interheart, and UK Biobank all agree when LDL-C and ApoB don't match, ApoB wins every time as the stronger predictor of cardiovascular events. So when there's a discordance, trust the ApoB particle count. Before we move on, let's place ApoB along its cousins. 1. Non-HDL-C. This is a calculation with total cholesterol minus HDL-C. It measures the cholesterol content of all atherogenic particles. This is still a mass measure, means a weight measure, not a particle number. 2. LDL particle. This is measured by nuclear magnetic resonance. It counts LDL particles only. It's similar to ApoB, but it is expensive. So if we have to rank them by accuracy or precision, ApoB is better than LDL particle, which is better than non-HDL-C, which is better than LDL-C. As you can see, we are all following LDL-C in our clinics, which is only the tip of the icebergs. The other available measures might give a better prediction of cardiovascular risk for our patients. Let's walk through how ApoB drives atherosclerosis. Imagine the endothelium as a selectively permeable road surface. Every ApoB-bearing lipoprotein that drifts too close has a chance to slip beneath the surface. Once it's trapped inside the endothelium, ApoB acts like a Velcro, the sticky surface. This binds to matrix proteoglycans, oxidizing and triggering inflammation. Macrophages, which are trying to rescue the situation, rush in and end up becoming foam cells and lay the groundwork for atherosclerotic plaque. It's not just one major hit, it's chronic exposure, particle after particle, day after day, hitting the endothelial wall and causing this damage. So when you see an ApoB value, you're really seeing how many chances the artery had to get hurt. In metabolic conditions like insulin resistance, LDL-C can look deceptively fine. The liver often churns out small, dense LDL particles, so they're more numerous. They have less cholesterol filled inside them, so that is why the LDL looks just fine. But the ApoB will be very high, and that is a risk underestimated. That's the hidden danger the ApoB unmasks. Okay, now that we know what ApoB represents, how do we actually use it? Good news, ApoB testing is practical, standardized, and inexpensive. It does not require fasting, and it stays accurate even when the triglyceride is high or LDL is very low, when Friedewald's calculation is not very reliable for LDL-C measurement. When to consider ApoB testing? 1. Strong family history of premature heart disease or severe dyslipidemias. 2. It is appropriate to test for both primary and secondary prevention. 3. High triglycerides, especially more than 200 mg per deciliter, diabetes mellitus, insulin resistance, or metabolic syndromes. 4. Major clinical changes such as new health conditions, significant weight changes such as obesity, medications such as antiretrovirals or glucocorticoids which affect lipids. 5. Optimizing therapy. When the LDL seems fine but the risk seems off, then checking the ApoB might be helpful. Guidelines, they all echo the same principle. Lower ApoB is better. Approximate cutoffs are less than 60 mg per deciliter for very high-risk patients, less than 70 mg per deciliter for high risk, and less than 90 mg per deciliter for intermediate risk. For details, you can check American Association of Clinical Endocrinology 2017's dyslipidemia guidelines and National Lipid Association 2024 ApoB consensus. The 2018 American Heart Association guidelines treat ApoB more than or equal to 130 mg per deciliter as a risk-enhancing factor. as it corresponds to LDL-C more than or equal to 160 milligram per deciliter, which is very high, by the way. This is especially considered to be useful when triglycerides are more than or equal to 200 milligram per deciliter. The new 2025 American Association of Clinical Endocrinology Dyslipidemia update interestingly notes that adding ApoB to the validated risk calculators doesn't dramatically change the scores or change the risk assessment, but they did identify it adds clinical judgment value in patients with discordant results or abnormal metabolic profiles. Lowering ApoB can be achieved through lifestyle changes and pharmacotherapy. Most LDL-C lowering therapies also lower ApoB, but to a different degree. Example 1. Statins, ezetimibe, bempedoic acid, PCSK9 inhibitors boost LDL receptor clearance of LDL particles, cutting both LDL-C and ApoB. 2. Microsomal triglyceride transport protein enzyme inhibitors, slomitopid, reduces the production of ApoB containing particles. 3. Fibrates lower the VLDL ApoB slightly, but have little effect on the LDL ApoB, which kind of explains their modest cardiovascular event reduction. In a meta-analysis of 29 trials and more than 300,000 patients, reductions in ApoB tracked directly with the reductions in cardiovascular events, no matter what drug was used for that purpose. And that's powerful. ApoB isn't just a biomarker, it's the unifying measure of atherogenic load. Let's put all these together with a case example. Meet Miss D, a 66-year-old with type 2 diabetes mellitus and prior scabbage 3 months post-stroke. She is on high-intensity statin. LDL-C is 68 milligram per deciliter. Its baseline was 145 milligram per deciliter. Current triglycerides are 210 milligram per deciliter, so high. And ApoB is 105 milligram per deciliter. Baseline was 125 milligram per deciliter. At the first glance, you're like, yeah, LDL-C looks great. 50% reduction from baseline. It is less than 70 milligram per deciliter. Mission accomplished, right? But observe the ApoB. 105 tells us there is persistent atherogenic particle overload. There's a residual risk hiding in plain sight. This patient is a very high risk for CVD. They have 2 different ACVD events and a metabolic syndrome. So they have a higher chance of having recurrent atherosclerotic event. So we can target a lower LDL-C. This is where we can consider intensifying therapy. We can add on ezetimibe or a PCSK9 inhibitor aiming for an LDL-C less than 55 milligram per deciliter and by extension lowering ApoB, and we might consider lowering up to less than 60 milligram per deciliter with the ApoB. So here are the take-home points. 1. ApoB counts particles, not cholesterol mass. It's the clearest measure of atherogenic burden. 2. When LDL-C and ApoB disagree, trust the ApoB. The particle count wins every time. 3. Use ApoB to unmask hidden risk in metabolic syndromes, hypertriglyceridemia, and discordant cases. It's simple, cheap, and clinically actionable. So next time you stare at a lipid panel, don't stop at what's the LDL-C. Ask instead how many atherogenic particles are really there, because that's the story ApoB tells, the truth behind the number. All right, folks, next episode is in 2 weeks, and we shall discuss lipoprotein(a), the terrible twin of LDL, and let's explore how it fits into the cardiovascular risk puzzle. Thanks for tuning into LipidCurious. If today's episode was helpful, share it with a friend or a colleague. I would love to hear suggestions, feedback, or even if you just want to connect, you can always reach me at hello@lipidcurious.com. Be sure to subscribe or follow so you don't miss what's next. And don't forget, you can download the free starter kit and season 1 visual guide at www.lipidcurious.com. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.